Okay, good morning everyone. Today we are going to do a case study presentation about a patient who is suffering from the lung cancer, and it is diagnosed with the non-small cell lung carcinoma. And my name is Tony Yao-Si Chong, and he is my group mate Justin Wong Jun-hin, and he will show up here later on. So here is our overview of our presentation. In our first part, we will include the epidemiology and the etiology, pathology, signs and symptoms, and some background information about our patient and his medical history, the treatment management and the chemotherapy, radiotherapy and surgery, and some advanced radiotherapy technique and prognosis. But the advanced radiotherapy technique does not include in our patient, so it is just a reference and some additional information about lung cancer. So let's talk about the epidemiology of the lung cancer in Hong Kong. So by the Hong Kong Cancer Registry in the 2017, it shows that it is the number 2 cancer of men in Hong Kong and number 3 cancer of women in Hong Kong last year. So in 2017, the male to female who's suffering from the lung cancer, the ratio is around 1.7 to 1. And there is a larger incidence for the elderly showing in this graph, and the overall incidence trend of male is higher than the female in all ages, and the male has a decreasing trend of having this disease. And also the Hong Kong Cancer Registry showed that it is the number 2 common cancer in 2017 in Hong Kong, and the number 1 cancer is colorectal cancer, just for reference. So let's talk about some etiology about this lung cancer. So the major risk factor of developing this cancer is tobacco smoke and secondhand smoke. So some other risk factors such as exposure to radon and air pollution. So the pathology. For the pathology, there are 2 main types of the lung carcinoma. The first one is the non-small cell lung carcinoma, which is it includes the squamous cell carcinoma and the adenocarcinoma and the large cell carcinoma. And also for another type of the lung cancer, which is the small cell lung carcinoma, which is more aggressive one. For the sign and symptoms, the patient may cough frequently and cough up the blood and feel tiredness and loss of appetite and have a weight loss and softness of the beef. Thank you. So let's discuss more about the patient background information. So for our patient, he is a male with 50 years old, and he has a smoking experience for over 20 plus years, and he smoked 1 pack per week. So this background information is very important, as we have already discussed smoking and also being male and elderly is a major risk factor of developing lung cancer. So these all background information are the risk factor that we discussed earlier. So he is very suspect to develop lung cancer. So the medical history of our patient. So he did the chest X-ray, which showed the left lung lesion, and then he do the bronchoscopy and biopsy to confirm non-small cell lung carcinoma. And later on, he do the PET scan, which showed the staging of the disease, which is stage 3 and no distant metastasis. So the treatment management of our patient, he first do the chemotherapy with Taxol and carboplatine, and then he do the RT to left lung and the mediastinal lymph node. The prescription is give 60 gray to 95% GTV in 30 fraction and up 5 fraction per week and then stop. So some study find that combining RT and chemo have a better survival rate than with neither alone. So for example, a study found that the overall 5-year survival rate from chemoradiation therapy was 32% better. So the main purpose of doing chemotherapy. So the first is to shrink the tumor and improve symptoms of the lung cancer to achieve the local control purposes. And the other one is first-line adjuvant or neoadjuvant therapy with the goal of cure. And the last one is to prolong life and relieve certain symptoms. So the Taxol and carboplatine are doing the intravenous infusion and over 60 minutes on day 1 and doing 2 cycles. So let's jump into the main thing, which is the radiotherapy. So this is the VMAC and the two field it used to apply it on the patient. So it used 6 MV beam energy and 2 half arc, and the field size is 15 times 15, and the SSD is 88 cm and 90.7 cm. So the dose fractionation we have already discussed, and the setup details is using the supine number one and using backlock and arms up. So this is the number one which can comfort the patient position so he can lie on it more stable. And the backlock can stabilize the body motion of the patient to stabilize its motion and to minimize the variation during intraflexion. So the reason to arms up is because when we radiate the lung, the beam will pass through the lateral side. So in case we don't want to radiate the arms, so the arms up position is to minimize the dose that hitting the normal tissue. So what is VMAC? The full name of VMAC is the volumetric arc therapy, which is using the linear accelerator to revolve around the patient and delivering a scope tightly focused beam of radiation directly to the tumor. It is a modulated beam continuously during the gantry rotation. So in VMAC, we can use 3 different arcs, like full arc 360 degree, and half arc 180 degree, and partial arc like butterfly VMAC, like 35 degree to 135 degrees. So for VMAC, the characteristics is also it use inverse planning in the planning section, which is like you input the dose, the lung you want it to receive how much dose, and then the planning system will automatically calculate and account for the OARs for you. So why we use VMAC instead of IMRT or 3D conformal RT? So in VMAC, it can spare more healthy tissue in the lungs because lung tissue are easily to be fibrosis in later on, which is something like a late side effect. So it can shorten the treatment times as well because the arc can rotate very fast. So it can also minimize the variation intraflexion. The third one is it can spare more organ at risk with using VMAC because the MLC will move and automatically shield and block the target region, such as the contralateral lung, ipsilateral lung, heart, esophagus, and also the spinal cord. So why we use 2 half arcs instead of 1 full arc? And why there is 179 degrees appearing in gantry rotation instead of 180 degrees? So the reason of using 2 half arcs is to protect the contralateral lung, which can significantly reduce the dose to the contralateral lung. And the reason of 178 degrees is because 180 degrees is equal to the gantry rotate from the clockwise and anti-clockwise rotation, but the gantry cannot rotate across 180 degrees. So inputting 179 degrees in the planning section can prevent the confusion in setting up.
For the side effects, the patient may feel the tiredness and feel pain when you are shadowing and cough. There is another type of the treatment, which is the surgery. It is the additional information for you. For the stage 1 and stage 2 non-small cell lung carcinoma, surgery is the primary treatment for this cancer. And also in the stage 3 non-small cell lung carcinoma, surgery is still the first choice for the treatment in the lung cancer. However, surgery cannot be possible in the stage 3 cancer under some conditions, such as the tumor is invaded to the chest wall, and there is an extensive medial-sternal metastasis. There are 3 main types of the surgery, which is the pneumonectomy and the lobectomy, and also the segmentectomy and the wedge resection. For the pneumonectomy, this surgery removes the whole lung, and this may be if the tumor is close to the center of the lung. The lobectomy is that the lung made up of 5 loops. In this surgery, the whole loop may be containing the tumor is removed. If it can be done, there is often the preferred type of the operation of the small cell lung carcinoma. For the remaining type, in this surgery, only part of the loop is removed. Tumor in the lung may move because of the normal breathing during the treatment. Therefore, the P3 need to be enlarged. However, some normal tissue may be irradiated. So we have two types of the advanced radiotherapy technique, which is the breath hold technique and the respiration gating technique. For the first one is the active breathing control. There is a small cap which is placed on the patient's nose to avoid the accidental breathing through the nose. And also there is the breathing tube, which is for the patient to breathe. And other is a small valve. Is used to block the additional air enter the lungs during the breath hold. For the respiratory gating technique, there are infrared tracking camera and the reflective marker used to measure the patient's respiratory pattern and the range of motion and displays them as a waveform. There is the prognosis of the non-small cell lung carcinoma. This is the reference. This is the end of our presentation. Thank you.
10分钟。